Hello guys, good evening. I welcome you all on Unacademy, India's largest learning platform. First of all, a little bit of introduction. Myself, Dr. Nidhi, I am alumni of King George Medical University, KGMU, Lucknow. I am teaching you all physiology. अगर NEET PG point of view से बात करें तो काफ़ी अच्छा विदेश रखता है. On an average, 15 to 17 questions come in our examination, so everybody clear the concept so that you can score more in your examination and you will be able to achieve your target with good rank. This is our Telegram page, that is Let's Crack NEET PG. Follow us out there so that you will get link of each and every class out here. This is my page on Unacademy, unacademy.com/@kgmc. Follow me out there so that you will get notification from the app. This is the code Dr. Nidhi. If you want to join any paid course, you can use this referral code to get additional 10% off. I've taken many plus classes, many special classes, so anytime you can join and revise the topic. This is our free test calendar for the week 4. ठीक है, these are the upcoming tests. Do join this test because tests are very important to analyze your preparation, to make yourself be prepared for your examination. These all tests are free. To unlock this all free test, you have to apply the referral code, that is Dr. Nidhi. So we are going to have this all India mock test. NEET PG 2022, if you are targeting this NEET PG 2022, do give this mock test. This we are going to have on 27th March 9 AM. Do remember the date and timing. This mock test is very important because it is going to see your benchmark of all India rank prediction, because we are going to have important question based on our previous year question. To enroll yourself, use this referral code Dr. Nidhi. Do remember the code, that is Dr. Nidhi. Now coming to the subscription, we have two type of subscription: plus subscription and iconic subscription. First, coming to this plus subscription. When you take plus subscription, you are able to access both live and recorded session. By chance, if any session is missed, you can see the recorded version. You have an opportunity to learn from India's top educator for the medical examination. We always conduct this live test and live quizzes. From that, you can analyze your preparation at any point of time. We have a flexibility. We can study from the device of your choice. आपका phone हमेशा आपके साथ होता है, तो आप phone से access कर सकते हो. If you want to go for the bigger screen, you can go for the bigger screen also. We have a question bank which consists of 25,000 plus question. High yield question है, clinical based question and with explanation है. So this is going to be very beneficial for all of you. Now coming to the iconic subscription, where you get access of India's two best platform, that is Unacademy and the PrepLadder. So you are going to get all the plus benefit from the Unacademy. Like I said, live classes, recorded classes, question bank, live tests and the live quizzes. Along with that, you get access for the PrepLadder. In this, you can access the clinical and integrated essential of PrepLadder, video lecture from the Dream Team, Question Bank 3.0, rapid revision and snapshot, and you will also be provided with their treasure and dream notes. So if you want to access the PrepLadder also, go for the iconic subscription, everybody. They are our FMG December 2021 topper. Special class feature. Our special class is also free of cost, but they are way more special from YouTube session. How they are special? Because our special class is always and always live. Live classes का benefit होता है, आप अपने एजुकेटर से इंटरैक्ट कर सकते हो, अपने डाउट को लाइव सेशन में क्लियर कर सकते हो. पोल्स के फीचर होते हैं, जैसे क्लास काफ़ी इंगेजिंग होता है. रेज हैंड फीचर्स देयर. नाउ यू कैन टॉक टू योर एजुकेटर इन द लाइव क्लासेस. अगर किसी एजुकेटर को फॉलो करते हो तो उनकी क्लास से प्रायर आपको नोटिफिकेशन मिल जाता है. After the lecture, you can download the PDF and revise it anytime, anywhere. This is the batch NEET PG 2022. If you are targeting, we are going to have this high yield MCQ marathon batch. Do join this one. This we are started, and this duration की अगर बात करें तो 2 month इसकी duration होगी. ग्रैंड टेस्ट होगा, सब्जेक्ट वाइज टेस्ट होगा. ठीक है, इसके लिए आपको रिकॉर्डेड क्लासेस भी मिल जाएगी अगर किसी वजह से आपका सेशन मिस हो जाता है. बट बेटर होगा कि आप लाइव इंटरैक्टिव क्लास ज्वाइन कीजिए. PDF notes after the lecture you will get. We have two modules, module 1 and module 2. In module 1 we are going to have MCQ discussion. 180 hours का इसका classes होगा. In module 2 अल्ट्रा फास्ट ट्रैक रिवीजन होगा, प्रीवियस ईयर क्वेश्चन होंगे एंड इसकी ड्यूरेशन होगी 150 आवर्स. This is also the batch we are going to start, that is FMG December 2022. अगर आपका टारगेट है तो we are doing this high yields revision and MCQ batch इसकी भी ड्यूरेशन 2 मंथ है, तो अपने रिक्वायरमेंट के हिसाब से आप अपना एनरोलमेंट कर लीजिए एंड अपनी प्रिपरेशन यू कैन स्टार्ट। सब्सक्रिप्शन फी की बात करेंगे तो वी हैव प्लस सब्सक्रिप्शन, वी हैव आइकॉनिक सब्सक्रिप्शन एंड वी हैव दिस लाइट सब्सक्रिप्शन। न्यूली एडेड है दिस लाइट सब्सक्रिप्शन, जहाँ पे आप टेस्ट सीरीज को एक्सेस कर सकते हो। फर्स्ट कमिंग टू द फी स्ट्रक्चर ऑफ प्लस सब्सक्रिप्शन, 2 मंथ की फीस है 7,650, 6 मंथ की फीस है 20,250, 9 मंथ की फीस है 22,500, 1 ईयर की फीस है 24,750, 18 मंथ की फीस है 29,250, 2 ईयर की फीस है 36,000, 36 मंथ की फीस है 45,000 एंड 48 मंथ की फीस है 54,000। सो अपनी रिक्वायरमेंट के हिसाब से आप अपना सब्सक्रिप्शन परचेस कर सकते हो। आइकॉनिक सब्सक्रिप्शन की अगर बात करेंगे तो 6 मंथ की फीस है 36,000, 9 मंथ की फीस हो जाएगी 39,600, 1 ईयर की फीस हो जाएगी 43,200, 18 मंथ की फीस हो जाएगी 49,500, 2 ईयर की फीस हो जाएगी 54,900 ओनली, 36 मंथ की फीस हो जाएगी 63,000 और 4 ईयर की फीस हो जाएगी 70,200 ओनली। लाइट सब्सक्रिप्शन बहुत ही इकोनॉमिकल है, 2 मंथ की सब्सक्रिप्शन भी है 2,163, मंथ की फीस है 2,700, 6 मंथ की फीस है 4,850, 9 मंथ की फीस है 5,400 एंड 1 ईयर की फीस है सिर्फ 5,940। दिस इज इंक्लूसिव ऑफ 10% डिस्काउंट। व्हेन यू अप्लाई माय रेफरल कोड 10% डिस्काउंट हो जाएगा एंड आपकी फीस समवॉट लाइक दिस वन। सो अपनी रिक्वायरमेंट के हिसाब से अपना सब्सक्रिप्शन परचेज कर लीजिए एंड अपनी प्रिपरेशन स्टार्ट कर दीजिए। Now coming to the important topic, today we are going to study about the regulation of respiration. This topic is very important. Our respiration is regulated by two mechanisms, either the neural mechanism or the chemical mechanism. For neural mechanism, the center are present in our brains. In brain, it is present in pons as well as medulla. For chemical regulation, we have the chemoreceptor cells. This chemoreceptor cell is sensitive to oxygen changes, carbon dioxide changes and hydrogen ion changes in our body, or you can say in our blood. So first coming to the undying curse. What is undying curse? Normally we all know our regulation is under the automatic control, but sometimes this automatic regulation of our respiration stop. In that situation, what happened? Patient has to consciously breathe in as well as breathe out. So this situation is seen during the bulbar poliomyelitis, it is seen during the carbon dioxide narcosis, and it is also seen during the disease process that compresses the medulla. So in all these three situations, we are going to have a patient which has to breathe in or breathe out consciously. Automatic regulation in this situation stops. So what is the treatment line? During the daytime, no issue. During the night time, patient has to be put into the ventilator. So this is very problematic situation. So now coming to the neural centers of respiration. We have two centers, neural center and chemical center. First coming to the neural center of respiration. This neural center of respiration is present in pons as well as medulla. So first coming to the pons. In pons we have two centers. We have Pneumotaxic Center which is present in upper part of pons, and we have this Apnea Center which is present in lower part of pons. So now coming to the medulla. In medulla we have three group of neuron. Dorsal respiratory group of neuron, ventral respiratory group of neuron and the pre-Botzinger complex. So coming to the detail of each one, first see this is the diagram. In pons we have two centers. We have Pneumotaxic Center which is present in upper pons. In lower pons we have Apnea Center. Next is the medulla. In medulla we have three centers. We have pre-Botzinger complex, we have dorsal respiratory group of neuron, we have ventral respiratory group of neuron. All these centers are responsible for regulation of respiration. How they are responsible we will see later on. So first coming to the pons. In pons, first is the Pneumotaxic Center which is present in upper pons. So what is the function of this Pneumotaxic Center? This Pneumotaxic Center limit the inspiration. How it is going to limit the inspiration? By inhibiting the apnea center. So what happened? Due to the limitation of inspiration, our respiratory rate increases. Is this clear? So what is the role of Pneumotaxic Center? It is going to limit the inspiration by inhibiting the apneustic center. Now coming to what does the apneustic center do? This apneustic center basically prolongs the inspiration. That's why we said Pneumotaxic Center limit inspiration by inhibiting apneustic center, because apneustic center is prolonging the inspiration. Is this clear with everybody? So moving further, now coming to the medulla. In medulla, we have this pre-Botzinger complex. This first pre-Botzinger complex is the pacemaker of respiration. Do remember, because this is responsible for initiation of respiration. That's why this pre-Botzinger complex is known as pacemaker of respiration. Next center that is present in medulla is dorsal respiratory group of neurons. This dorsal respiratory group of neuron is responsible for generation of RAM signal. So this dorsal respiratory group of neuron is responsible for generating the RAM signal. What does this RAM signal do? It is responsible for steady rise in tidal volume. We all know our tidal volume is 500 ml. So initiation of respiration is done by pre-Botzinger complex, and this achievement of 500 ml tidal volume is done by dorsal respiratory group of neuron. This dorsal respiratory group of neuron is going to generate the RAM signal, and that is responsible for this steady rise in tidal volume. And the last center, that is ventral respiratory group of neuron. This ventral respiratory group of neuron has no role during the our normal respiration. ठीक है, तो इसका फंक्शन कहाँ आता है? It works during the forceful expiration, like during the exercise. Because we all know our normal expiration is a passive process, and this ventral respiratory group of neuron is helping in expiration. So normal respiration में it has no role. So its role come when we have to forcefully expire, like during exercise. So what does this do? This ventral respiratory group of neuron is providing the extra respiratory effort. That's why it is also called as extra respiratory drive or overdrive phenomena. Is this clear with everybody? So we have Pons center and we have centers present in medulla. In Pons we have Pneumotaxic center that is present in upper Pons, which is inhibiting the inspiration. Next was the apneustic center, which is present in lower Pons, that was prolonging the inspiration. In medulla we have pre-Botzinger complex, which is acting like a pacemaker of respiration. Next was the our dorsal respiratory group of neuron, that was responsible for steady rise in tidal volume. Next is the ventral respiratory group of neuron, that is responsible for forceful expiration, like during exercise. Now moving further to this one, pneumotaxic center, we already studied that it inhibits the apneustic center, and the vagal afferent from lung also inhibit the apneustic center. So these both, the pneumotaxic center and the vagal afferent, is going to limit the inspiration by inhibiting the apneustic center. So do remember, beside pneumotaxic center, our vagal afferent from lung is also going to inhibit the apneustic center. Is this clear with everybody? So moving further to the integration part, how our respiration is integrated. The first is the inspiration. First in this we have initiation of respiration. So we already studied the initiation occur from the pre-Botzinger complex. So we can say initiation of inspiration occurs in medulla. So what happened? The pacemaker is responsible for initiation. So the signal goes to the diaphragm via the spinal cord C3, C4 and C5 nerve. So via the phrenic nerve it goes to the diaphragm, and the diaphragmatic contraction occur, and that is going to cause inspiration. So is this clear? Initiation of inspiration occurs in medulla. Medulla में कहाँ हो रहा है? Pre-Botzinger complex. From there the signal goes to the diaphragm via the phrenic nerve, that is C3, C4 and C5 nerve roots, and that is going to cause diaphragmatic contraction, and that is going to cause inspiration. So this is important. Our pre-Botzinger complex is the pacemaker, so our respiration is involuntary. ठीक है, स्टार्टिंग में बताया था और respiration is involuntary, but if the pre-Bonzinger complex is absent, क्या हो जाएगा? Our automatic control of respiration will stop. The patient has to breathe in and breathe out consciously, and this is seen during the carbon dioxide narcosis, and this phenomena is known as on-dying curse. And the treatment line out here is providing the mechanical ventilation during the sleep. Is this clear? After the initiation, now coming to the next point, that is how the inspiration is maintained. So now coming to the maintenance of inspiration. So maintenance मतलब हमारा tidal volume 500 ml तक जब reach होता है, that is maintenance. So this, how does it work? Apnea center that is present in lower pons is going to activate the dorsal respiratory group of neuron, and we all know dorsal respiratory group of neuron is going to generate the RAM signal, and that is responsible for steady rise in tidal volume. Is this clear with everybody? Moving further, now the last point, that is how the inspiration is terminated. After reaching the tidal volume of 500 ml, inspiration should stop. And how to stop? The Pneumotaxic Center and the vagal afferent from the lung is going to inhibit the Apnea Center. And that's why what happened? Apnea center is inhibited, so our dorsal respiratory group of neuron will be inhibited, and that's why RAM signal will not be produced and inspiration will be terminated. Is this clear, everyone? So this is about integration of inspiration, initiation, prolongation, and next is the termination. Everybody, is this clear? Now moving further to the neural central lesion, how they are going to affect our respiration. So different level पे lesion हो सकता है. First is the lesion below the medulla. So what happened? Pre-Bonzinger complex in this situation is working, but the pre-Bonzinger complex is not going to send the signal to the diaphragm because lesion is below the medulla. So diaphragmatic contraction will not be there, and due to that क्या होगा, हमारा initiation of inspiration will not occur. So in this situation, our respiration will stop and death is for sure. First situation clear है? Lesion below the medulla से क्या होगा? Pre-Bonzinger complex cannot activate the spinal cord, so there is no initiation of inspiration. There is no diaphragmatic contraction, so respiration stops, so death is for sure. Next lesion, that is pontomedullary junction lesion. Means the lesion is between the pons and medulla. What does pons do? Pons regularize the respiration. Medulla initiate the respiration. Do remember, medulla initiate the respiration, pons regularize the respiration. Lesion is between this pontomedullary junction lesion. So in this situation, medulla will be working, but pons will not be working. So initiation of respiration will be there, but regularization of respiration will not be there. So in this situation, we will get the irregular respiration. Is this clear, everyone? Now coming to the next lesion, that is Metapontang lesion, and along with that vagus nerve is also cut. So what happened in this situation? Let me draw a diagram for all of you. This is our upper pons, this is our lower pons, and this is our medulla part. So this lesion is Metapontang lesion. So in this situation, what happened? Lower pons, which is consisting of this apnea center, will be working, but upper pons will not be working. So Pneumotaxic center will not be working in this situation. So what happened? What does the apnea center do? It prolongs the inspiration. So due to prolongation of inspiration, हमारा जो inspiration यहाँ पे होगा, that is apnea breathing. ठीक है? So in this situation, apnea center is not inhibited by pneumotaxic center, as well as vagus nerve is also cut. So apnea center is going to increase the inspiration. So this type of breathing is known as apneustic breathing. So this is the diagram. This is the normal breathing and this is the prolonged inspiratory spasm. So this type of breathing is known as apneustic breathing. Is this clear? So how this different lesion is going to affect our respiration. Is this clear with everybody? See, this is the diagram. This is first lesion that is below the medulla. So when lesion is below the medulla, our signal will not reach to the spinal cord. Okay, so that's why our diaphragmatic contraction will not be there. So respiration will not be there in both situations if vagus is intact or vagus nerve is cut. First situation. Second situation is pontomedullary junction lesion. So in this situation, what happened? Our pons will not be working, only and only medulla will be working. So in this situation, we are going to get the irregular breathing. Next is the Metapontang lesion. In Metapontang lesion, what we are going to see, our apneustic center will not be inhibited by Pneumotaxic Center. But if vagus is intact, it is going to inhibit the apneustic center. So in this situation, we are going to see this regular breathing. But if vagus nerve is also cut, so in that situation, क्या हुआ? हमारा apneustic center is not inhibited by vagus as well as our Pneumotaxic center. So in this situation, we are going to see this prolonged inspiratory spasm and this type of breathing is known as apneustic breathing. Okay? And last, the lesion above the pons. In this situation, we are going to have this regular breathing. Is this clear with everybody? So moving further to the pulmonary reflexes. Different type of pulmonary reflexes are there. Three important pulmonary reflexes are there. Herring-Brewer reflex, head paradoxical reflex and the J reflex. First is the Herring-Brewer reflex. This is a classical example of negative feedback. How it is a classical example? We will discuss that one. So in this Herring-Brewer reflex, we have two type of reflex. We have inflation reflex, we have this deflation reflex. First, coming to the important point, this Herring-Brewer reflex is conducted by slow adapting myelinated vagal afferent. Do remember, this is important from exam point of view. This Herring-Brewer reflex is conducted by slow adapting myelinated vagal afferent. Now coming to the reflex. First is inflation reflex. This is also a classical example of negative feedback. How it is a classical example, we will discuss that one. So it is a type of a protective reflex that prevent the lung from injury. How it is preventing our lung injury? In this, what happened? Inflation of lung is going to inhibit further inspiration. So this is a classical example of negative feedback, and since it is preventing the further inspiration, so it is going to prevent the lung from injury. How it works? It inhibits the inspiration, it decreases the duration of inspiration and it increases the duration of expiration. ठीक है, अब बात करेंगे when this inflation reflex work, over inflation of tidal volume. When over inflation of tidal volume up to 1500 ml occurs, then this inflation reflex work. ठीक है, कैसे वर्क करता है? जैसे ही हमारा वॉल्यूम 1500 ml पहुंच जाएगा, उस सिचुएशन में no further inspiration will be occurring, our inspiration will be inhibited, our expiration will be start, so expiration starts. So that's how our inflation reflex work. Is this clear with everyone? Now coming to the next, that is deflation reflex. It is also a classical example of negative feedback and it is also a protective reflex. It prevents the lung from collapsing. So how does it work? Deflation of lung is going to inhibit further expiration. So our lung will be prevented from lung collapse. Is this clear? And how does it work? It inhibits expiration, it decreases the duration of expiration and it increases the duration of inspiration. So what happened in this situation? Prolonged expiration is going to inhibit the expiration and our inspiration is started. So this is our deflation reflex. It is also a protective reflex. It is also a classical example of negative feedback mechanism. Everyone, is this clear? Moving further, next reflex, head paradoxical reflex. Herring-Brewer reflex was a classical example of negative feedback mechanism, but this head paradoxical reflex is a different one. It is opposite to Herring-Brewer reflex. How does it is different? See, prolonged inspiration out here is going to increase the inspiration. Means inflation of lung is going to augment further inflation of lung. So this is just opposite to our inspiration reflex. Herring-Brewer inflection reflex. Is this clear? So what is the significance of this head paradoxical reflex and when does it occur? This is important from exam point of view. It occurs during the first breath of newborn. During the first breath of newborn, our inflation of lung is going to augment further inflation of lung, and that is important out there. Okay, and with this what happened? All the fluid that is present in lung is replaced with the air. With this head paradoxical reflex, all the fluid that is present in the fetus lung, that is replaced with the air. So this is clear with everybody. Next is the head paradoxical reflex. Everyone, moving further to the next one, that is J reflex. This is very, very important from exam point of view. This J reflex is due to a receptor that is present juxtaposition to the pulmonary capillary. Due to its location that is juxtaposition to the pulmonary capillary, this receptor is known as J reflex. Okay? And this receptor is known as J receptor. This J reflex is studied by A.S. Pentol. When does this J reflex occur? Do remember, this is important. J reflex occur in the situation of pulmonary congestion, in the situation of pulmonary embolus, and in the situation of pulmonary edema. See what happened. Since in the patient of pulmonary edema, it is seen in the patient of pulmonary edema and it is causing the breathlessness. What does happen? When fluid extravasate from the pulmonary capillary, this J receptor which is present at the juxtaposition, this is our pulmonary capillary, okay? This is interstitium. Okay? So this is the J receptor that is present in juxtaposition to the capillary in the interstitium. When fluid extravasate to the pulmonary capillary, it is going to stimulate this J receptor, and this J receptor is going to cause J reflex, and this J reflex include apnea, breathlessness, hypotension, and the bradycardia. Is this clear with everybody? So this J reflex include apnea, breathlessness, hypotension, and the bradycardia. This J reflex is seen in situation of pulmonary congestion, pulmonary edema, pulmonary embolism. Okay, is this clear? So now coming to the next important point, this J reflex is conducted by unmyelinated C vagal fiber. Herring-Brewer reflex was conducted by myelinated fiber, slow adapting myelinated fiber. This J reflex is conducted by unmyelinated C vagal fiber. Clear? Everybody? सारे reflex clear हुए. Herring-Brewer reflex, we have head paradoxical reflex, we have this J reflex. Moving further to the different altered breathing pattern. This altered breathing pattern is seen during the lesion in our neural areas. So first type of altered breathing pattern is kinestotic breathing. This kinestotic breathing is characterized by a gradual hyperapnea, gradual hypoapnea, and it is followed by apnea. So it is characterized by gradual hyperapnea, gradual hypoapnea, and it is followed by apnea phase. ठीक है. Next, coming to the causes of this kind of stroke breathing. This kind of stroke breathing is normal during the sleep situation. It is seen during the congestive cardiac failure. It is seen during the uremia situation. Next, that is Biot's breathing. This Biot's breathing is seen in, what is the characteristic? First, coming to the characteristic, in this we are seeing this irregular breathing pattern and it is followed by apnea. So this is the Biot's breathing, which is characterized by irregular breathing followed by apnea phase. So this is the Biot's breathing. This Biot's breathing is also known as ataxic breathing pattern, and this is seen during the onto-medullary junction lesion we already discussed, and it is also seen during the meningitis situation. So we have this kind of stroke breathing, we have this Biot's breathing, and next coming to the Kussmaul's breathing. This Kussmaul's breathing is a form of hyperventilation. In this, both rate and depth of respiration is increased. ठीक है. Kussmaul's breathing, it is a form of hyperventilation in which both rate and depth of respiration is increased. And now coming to this point, when this Kussmaul's breathing is seen. This Kussmaul's breathing is seen during the diabetes mellitus patient who is suffering from diabetic ketoacidosis. In this situation only we see this Kussmaul's breathing. ठीक है. Everybody, is this clear? So we have kinestroke breathing, we have Biot's breathing, and we have this Kussmaul's breathing. So see, this is the summary. We have this eupnea, which is what is known as eupnea. Eupnea is our normal breathing pattern. What is tachypnea? Tachypnea is increased respiratory rate. What is bradypnea? It is decreased respiratory rate. What is apnea? That is absence of breathing is seen. What is hyperapnea? Rate of breathing is normal, but depth of breathing out here is increased. Kinestroke breathing, gradual hyperapnea, gradual hypoapnea followed by apnea phase. What is Biot's breathing? Biot's breathing is irregular respiration followed by this apnea phase. What is Kussmaul's breathing? In Kussmaul's breathing, we see this tachypnea as well as hyperapnea. Both respiratory rate and depth increases in Kussmaul's breathing. Next is the apneustic breathing. In this, we have prolonged inspiratory spasm, and this is known as apneustic breathing. Is this clear with everybody? Moving further, this is the diagram. This is eupnea. This is kinestroke breathing. This is Biot's breathing, irregular breathing followed by apnea. This is Kussmaul's breathing, which is both in the respiratory rate and depth increases. This is apneustic breathing, in which we are seeing this prolonged inspiratory spasm. Moving further to the chemical regulation. After the neural regulation, coming to the chemical regulation of respiration. This respiration, for chemical respiration regulation, we have the chemoreceptor. That chemoreceptor are sensitive to oxygen change, carbon dioxide change, and hydrogen change in our body. So now coming to the chemoreceptor. Where are they located? The location of chemoreceptor, they are located in brain as well as in neck. In brain, the chemoreceptor are known as central chemoreceptor. In neck, it is known as peripheral chemoreceptor. The central chemoreceptor are located in ventral surface of medulla, and it is surrounding the floor of fourth ventricle. Peripheral chemoreceptor are present in carotid body and aortic body. Okay? See, this is the diagram. This is the carotid body. This carotid body is present at bifurcation of common carotid artery. Okay? So this is the carotid body. This is the aortic body, which is present in our aortic arm. For chemoreceptor, we have this carotid body, we have this aortic body. For Our cardiovascular system, we have baroreceptor. For regulating our blood pressure, we have baroreceptor, which is present in carotid sinus and aortic sinus. So don't confuse with this baroreceptor with the chemoreceptor. Chemoreceptor are carotid body and aortic body, not the sinuses. Is this clear with everybody? Moving further to the regulation part, first coming to the central chemoreceptor, which is present in our neck region. The most important point out here is central chemoreceptor detect the oxygen change. Sorry, carbon dioxide change. And our normal respiration is also carbon dioxide dependent. So what happens? See, whenever there is increase in carbon dioxide, there will be increase in hydrogen ion also. So, but only and only this carbon dioxide crosses the blood-brain barrier, not the hydrogen ion. So what happened? When it crosses the blood-brain barrier inside the brain, it is going to react with the water in the presence of carbonic anhydrous, and it is going to form carbonic acid. This carbonic acid associates to form hydrogen ion and the bicarbonate ion. And this hydrogen ion is going to stimulate the central chemoreceptor. So these 2 points are very important. Our central chemoreceptor के लिए जो हमारा blood brain barrier को क्रॉस कर रहा है, that is only and only carbon dioxide is crossing, not the hydrogen ion. ठीक है, but जो हमारा stimulate कर रहा है central chemoreceptor को, that is hydrogen ion, not the carbon dioxide. So these 2 points are very important from the exam point of view. So these 2 statements are central chemoreceptor are sensitive to carbon dioxide change, but it is directly stimulated by hydrogen ion in the CSF. It is sensitive to carbon dioxide, but it is stimulated by hydrogen ion in CSF. Is this clear with everybody? So these 2 points are very, very important from the exam point of view. Moving further, now coming to the next receptor that is present in our neck region, that is peripheral chemoreceptor. Central chemoreceptor are carbon dioxide sensitive. They detect the carbon dioxide change in our body, while the peripheral chemoreceptor is going to detect the decrease in partial pressure of oxygen, or you can say detect the hypoxia situation. Now coming to the peripheral chemoreceptor. This peripheral chemoreceptor is present in our neck region in the form of carotid body and aortic body. These 2 bodies consist of a glomus cell. This glomus cell is important for its regulation because this glomus cell consists of oxygen sensitive potassium channel, which senses this hypoxia. So what happened during the hypoxia? This oxygen sensitive potassium channel gets closed, and potassium channel close ho jayega, so what will happen? Our potassium efflux will stop. Potassium is going to accumulate inside the cell. So inside the glomus cell, potassium ion will increase, and since positive ion is accumulating inside the cell, membranal depolarization will occur, and that is responsible for opening of calcium channel. Our calcium channel will open up when the potential reaches to plus 40 millivolt, okay? And that is going to bind with the neurotransmitter vesicle, that is going to bind with the dopamine vesicle, and dopamine will be released, and this dopamine reaches the brain and it causes the chemoreflex. ठीक है, clear हुआ? Whenever there is hypoxia, it is going to inhibit this oxygen sensitive potassium channel. Let me draw this one for all of you. Suppose this is our glomus cell. This glomus cell consists of this oxygen sensitive potassium channel. So what happened during the hypoxia situation? This oxygen sensitive channel get closed, and due to that our potassium efflux will stop, and that is going to cause accumulation of this positively charged ion inside the cell. And since positive ion is accumulating inside the cell, membranal depolarization will be seen, and due to the membranal depolarization, what happened, हमारा calcium channel open up हो जाएगा, calcium influx will be there, and this calcium is going to bind with the neurotransmitter vesicle, and exocytosis of neurotransmitter will occur, and this neurotransmitter is going to reach the brain, and that is going to cause chemoreflex. See, this is the same diagram. Due to hypoxia, our oxygen sensitive channel closes, membranal depolarization occur, voltage gated calcium channel open up, calcium entry will be there, and that is going to cause exocytosis of neurotransmitter. This neurotransmitter reaches the brain and is going to cause chemoreflex. Now, this is the important one. Do remember, everybody, our central chemoreceptor is stimulated by increase in carbon dioxide concentration as well as increase in hydrogen ion level. Okay? Our peripheral chemoreceptor is stimulated by our decrease in oxygen concentration and increase in hydrogen ion concentration. So this is the common stimulus that activate our both central chemoreceptor as well as peripheral chemoreceptor. So now coming to the common stimulus that activate both receptor is increase in hydrogen ion, or you can say fall in pH. Decrease in blood pressure is also going to activate these two receptors. So decrease in blood pressure is also going to cause the chemoreflex. Is this clear with everybody? Moving further, what is the chemoreflex? Due to asphyxia, that is hypercarbia, hypoxia, acidosis, our chemoreceptor are stimulated, our central chemoreceptor are stimulated, our peripheral chemoreceptor are stimulated, and that both is going to cause this chemoreflex. This chemoreflex includes the hypoventilation. This hypoventilation includes both increase in rate and the depth of breathing, and due to that carbon dioxide washout will be there. Carbon dioxide in our blood will decrease, hydrogen ion in our blood will decrease, and that is going to increase the oxygen in our blood. This is our chemoreflex. Is this clear, everyone? So chemoreflex include hyperventilation, in which rate and depth of breathing both increases, and that is going to cause carbon dioxide washout, oxygen concentration increases in our blood, carbon dioxide concentration decreases in our blood. Is this clear with everybody? So this is about the chemoreflex. Anybody? Any query? Moving further to the question part. First question of today's session. Everybody answer in the comment section. First question is, pacemaker of respiration or spontaneous rhythmic respiration is initiated in dorsal nuclear group, Apnea Center, Pneumotaxic Center, or the pre-Botzinger complex. Everybody answer this question. The pacemaker of respiration or spontaneous rhythmic respiration is initiated in, I guess easy है. Pacemaker of respiration or spontaneous rhythmic respiration is initiated in. Pacemaker of respiration is pre-Botzinger complex. Coming to the next question, If a cat apneutic center was destroyed along with the vagus cut, which of the following statement is correct regarding the breathing pattern seen in a cat? Prolonged inspiratory spasm will be there. Prolonged expiratory spasm will be there. Slow and shallow respiration, or animal will die. Everybody answer this question. If a cat apneutic center is destroyed along with the vagus cut, which of the following statement is correct regarding the breathing pattern seen in the cat? So in this situation, what happened? Our pneumotaxic center will be only working. Pneumotaxic center will be working. And what does pneumotaxic center do? It inhibits inspiration and it start the expiration. So it is going to inhibit the inspiration and it is going to start the expiration. In this situation, we are going to have this prolonged expiratory spasm. Is this clear with everybody? Coming to the next one, inspiratory depth is halted by pneumotaxic center, apneutic center, inspiratory center, or expiratory center. Inspiratory depth is halted by. Everybody answer this question. Easy now. Inspiratory depth is halted by our pneumotaxic center. Coming to the next one. Transaction at mid-Pons level result into hypoventilation, apneutic breathing, rapid and shallow breathing, or hypoxia. Everybody answer this question. Transaction at mid-Pons level result in transaction at mid-Pons level result into mid-Pons level पे lesion है. What will happen? What will happen? In this situation, our pneumotaxic center will not be working. only and only apneustic center will be working, and due to apneustic center working, our inspiration will be prolonged, and that is going to cause apneustic type of breathing. So answer is the B. Coming to the next, what is the effect on respiration if transmission is met between the pons and medulla? Apnea will be there, irregular or gasping breathing will be seen, no effect or slow and deep respiration will be seen. Everybody answer this question. What will be the effect on respiration if transmission is met between the pons and medulla? Everyone answer this question. What will be the effect on respiration if transmission is between pons and medulla? What will happen in this situation? Pons is not working, only and only medulla is working. What does pons do? It regularize the respiration. What does medulla do? It initiate the respiration. So in this situation, we are going to have this irregular breathing. Answer is B. Clear, everyone? Coming to the next one, true regarding respiratory center is directly stimulated by fall in partial pressure of oxygen, stimulate inhibited during the swallowing, connected with the cardiac center, situated in midbrain. So everybody answer this question. Which of the following statement is true regarding the respiratory center? Everybody answer this question. Which of the following statement is true regarding respiratory center? First statement, directly stimulated by fall in partial pressure of oxygen. No, it is directly stimulated by increase in carbon dioxide level. It is inhibited during swallowing. This statement is true. It is not connected with the cardiac center. It is situated in pons and medulla, not in the midbrain. So answer is B only. Is this clear with everyone? So answer is B. Coming to the next question, central chemoreceptor is most sensitive to the following changes in the blood: increase in partial pressure of carbon dioxide, decrease in partial pressure of carbon dioxide, increase in hydrogen ion, or increase in partial pressure of oxygen. Central chemoreceptor are most sensitive to following changes in the blood. Everybody answer this question. Central chemoreceptor are most sensitive to following changes in blood: increase in partial pressure of carbon dioxide, decrease in partial pressure of carbon dioxide, increase in hydrogen ion, increase in partial pressure of oxygen. Central chemoreceptor are most sensitive to increase in partial pressure of carbon dioxide. Very true. Coming to the next, the primary direct stimulus for the excitation of central chemoreceptor regulating ventilation is increase in hydrogen ion, increase in carbon dioxide, increase in oxygen, or decrease in carbon dioxide. Everybody answer this question. The primary direct stimulus for excitation of central chemoreceptor regulating ventilation is the primary direct stimulus for excitation of central chemoreceptor is डायरेक्ट स्टिमुलस की जब बात करेंगे आंसर इज इंक्रीज इन हाइड्रोजन आयन. दोनों स्टेटमेंट समझ में आया? फर्स्ट क्वेश्चन वाज chemoreceptor cell are most sensitive to increase in partial pressure of carbon dioxide. most sensitive हमारा partial pressure of carbon dioxide increase से. and direct stimulus की बात करेंगे तो hydrogen ion is going to directly stimulate our central chemoreceptor. So both statements are very important. Coming to the next, the most important stimulus to the peripheral chemoreceptor is partial pressure of oxygen, carbon dioxide, pH, or the bicarbonate. Everybody answer this question. The most important stimulus to the peripheral chemoreceptor is most important stimulus to peripheral chemoreceptor is most important stimulus for peripheral chemoreceptor is hypoxia. A decrease in partial pressure of oxygen is going to stimulate our peripheral chemoreceptor. Answer is A. Coming to the next one, peripheral and central chemoreceptor both contribute to increase in ventilation occur due to result of decreased arterial blood pressure, arterial tension, arterial oxygen concentration, or the hydrogen ion. Peripheral and central chemoreceptor may both contribute to increased ventilation that occur as a result of decreased Everybody answer this question. Peripheral and central chemoreceptor may both contribute to increased ventilation that occur as a result of decreased it is caused due to decrease in blood pressure or increase in hydrogen ion concentration, or you can say decrease in the pH. So answer is only and only A. Is this clear with everyone? Coming to the next one, which of the following doesn't stimulate our peripheral chemoreceptor? Hypoxia, hypocapnia, acidosis, or low perfusion pressure? Which of the following doesn't stimulate our peripheral chemoreceptor? Everybody answer this question. Which of the following doesn't stimulate peripheral chemoreceptor? Hypoxia, hypocapnia, acidosis, or low perfusion pressure? See, our hypoxia is going to stimulate the peripheral chemoreceptor. Acidosis is going to stimulate our peripheral chemoreceptor. Low perfusion pressure, that is low blood pressure, is going to stimulate the peripheral chemoreceptor. Answer is only and only hypocapnia. Coming to the next verse, one, administration of pure oxygen to the hypoxic patient is dangerous because apnea is going to occur due to hypostimulation of peripheral chemoreceptor, pulmonary edema, DPG, or the convulsion. Why the administration of pure oxygen to the hypoxic patient is dangerous? Administration of pure oxygen to the hypoxic patient is dangerous. Why is it so? Because अगर hypoxic patient को we give this pure oxygen, normally क्या होगा, hypoxic situation में our peripheral chemoreceptor is stimulated, but in this situation what happen, hypostimulation of peripheral chemoreceptor will be there and that can lead to the apnea. So that's why it is dangerous. So answer is A. Is this clear with everyone? Coming to the next one, tidal volume excessive load is prevented by activation of which of the following receptor? G receptor, thoracic muscle sphincter, bronchial stretch receptor, or arterial baroreceptor? Tidal volume excessive load is prevented by activation of which of the following receptor? Everybody answer this question. Tidal volume excessive load is prevented by activation of which of the following receptor? Excessive load में हमारा क्या था? Peripheral reflex start and that is due to activation of bronchial stretch receptor. Answer is C. Is this clear with everyone? Coming to the next one, inflation of lung induces further inflation. It is explained by Hering-Muir inflation reflex, Hering-Muir deflation reflex, head paradoxical reflex, or the J reflex. Inflation of lung is going to induce further inflation. And this is explained by inflation of lung induces further inflation. This is opposite to the Hering-Muir inflation reflex. It is explained by head paradoxical reflex. Answer is C. Clear everybody? Moving further, all of the following affect resting ventilation except stretch receptor, J receptor, oxygen or partial pressure of carbon dioxide. All of the following affect resting ventilation except everybody answer this question. Or J receptor. This work during pulmonary congestion, pulmonary edema, pulmonary embolism. This doesn't work during normal situation. Answer is B. Is this clear with everybody? Coming to the, okay, that was the last question of today's session. Hope you all like this session, everyone. So if you like this session, do like and share. This is important. जितना ज़्यादा शेयर करोगे क्लास उतनी इंटरैक्टिव होती है. So do share everybody and subscribe our channel. That is Let's Crack NEET PG. And press the bell icon so that you'll get notification of every classes and you won't miss a single class. This page is also available on the Telegram. You can also follow us out there also. So thank you so much everyone for joining. See you all in the next session. Regular mehnat karte rahiye. You will definitely able to achieve your target with good rank. So this is the referral code. Lastly, this is the referral code Dr.Nidhi. If you want to join any paid course, you can use this referral code to get additional 10% off. This referral code is valid for each and every examination. So any friend of yours or any family member of yours, if they are willing to take Unacademy subscription, they can also use this referral code to get additional 10% off. That's all for today. Thank you so much everybody for joining. See you all in the next session. Bye bye everyone.